Good morning, everybody. I'd like to welcome you all to Mount Sinai Cath Lab today for another interesting case in our CCC live case peripheral edition, as we call it, on the last Wednesday of the month. I know this is an odd start today because, as everyone knows, today's the first day of TCT, and our regular team of Dr. Guja, Dr. Kapoor, and Dr. Kukar have all been assigned in TCT and leaving the rest of us working class to work here in Mount Sinai. But this gives us an opportunity to really work with one of our very dear friends and somebody who's been an incredible collaborator and partner in taking care of these complex patients in peripheral arterial disease from the Department of Surgery here at Mount Sinai. He's agreed to be our moderator today in very last minute notice, and I really appreciate him taking time out of his busy schedule to join us. So I'd like to introduce Dr. Ajit Rao, who is an assistant professor of vascular surgery and a director of research in the Department of Vascular Surgery at the Icahn School of Medicine and the Mount Sinai Hospital. And Ajit, thank you so much for joining us. I know it was last minute, and it was really a thrill for us to have you here and give your input and your experience into handling this very, very complex patient. So on behalf of our entire audience and all of us here, we welcome you. And just for everybody to know, as you know, in background, we've had Dr. Peter Ferries has been one of our moderators multiple times. Dr. Dan Hahn has been our moderator multiple times. Dr. Pablo Kim and Dr. Tadros, and as well as before, have actually scrubbed in and done cases with us. And so it's a thrill that Dr. Rao would join us. Thanks so much, Ajit. I really appreciate it.
Of course. Thanks for having me.
So Ajit, we have a very interesting case to present to you and also to the audience. So without further ado, I want to give it to our actually, let me introduce my team. To my right is Dr. Haroon Cameron, our endovascular fellow. He's been kind enough to join us from downstate in Brooklyn. To my left is Ray Lascano, our nurse practitioner. To my right is our interventional fellow, who is kind enough to assist us in this procedure. And our nurse, as always, is Elizabeth, and our tech is Damien. So Haroon, without further ado, go ahead, buddy.
Sure.
To our slides, please.
Okay, so I'm going to present the presentation. Our patient is a 79-year-old gentleman with a past medical history of hypertension, hyperlipidemia, diabetes, coronary artery disease, and smoking. He presents with, can you hear me?
Yep,
okay.
Can hear you.
He presents with worsening bilateral lower extremity claudication that is more on the left than right, to have a block, Rutherford 4, that has now progressed to pain at rest. The patient is currently on aspirin, clopidogrel, atenolol, losartan, ranolazine, atorvastatin, and remains symptomatic despite the treatment. His most recent ABI done is 0.71 on the right and 0.68 on the left. The patient had a non-invasive workup, including an arterial Doppler that shows bilateral SFA disease. And on the left side, he was found to have a possible occluded popliteal artery with severe below-the-knee disease. The patient had an angiogram done. The runoff is shown here that shows a severely calcified SFA with a popliteal obstruction, as you can see below the knee. It reconstitutes at the level of mid-calf with a two-vessel runoff to the foot with a PT and peroneal.
So Ajit, I think we're going to stop there and just kind of discuss here. Let me show you today's angiogram. So as Haroon spoke, we've got a guy who's claudicant progressing to rest pain. He has, forget the right leg here, it's not really bothering him. He's had an intervention in the past, which shown that he has some moderate SFA disease. There's increased velocities at that level in the mid SFA above the stent, which has a PSVR on 325 here. He has resting ABIs of 0.71 or something?
Yes,
0.6, whatever it was. Not really critical ABIs in terms of rest pain, but he's a relatively young gentleman who's quite active and really has a lot of symptoms in his foot. So you can see in the past what they tried to do was open up the SFA and increase collateralization to the foot. But then you can see here in the distal, the SFA occludes, actually the popliteal occludes. He has an incredibly large genicular collateral, both coming from the SFA and the pop. And the genicular collaterals actually go ahead and very distally reform the posterior tibial. I believe that's maybe a faint anterior tibial coming, or maybe a collateral, and the perineal. And then when you go down to the foot, you can see that at the level of the foot, you definitely have two vessels in the foot. So to me, the reason we decided to choose this case is it really provides us with a lot of information or a lot of questions on how to manage. So here's a gentleman, obviously, who has a lot of risk factors and has significant claudication. He's a youngish patient who possibly is a candidate for surgery. So I guess my question to you is, obviously we do the same things in different ways. You're able to do bypass as well as endovascular. I'm only able to do endo. What is the approach, your approach as a surgeon to these kind of patients? What is your decision making? That's my question.
Sure, of course. So I think with every patient, I always break it down into all the options I have. So in every case, it's medical, endovascular, and open surgery options. So for him, medical, as he's having rest pain, he's progressed to rest pain, he's, critical limb ischemia. I don't think that's a good option. And someone that, perhaps has intermittent claudication, I would consider an exercise program or Celastazole first. But again, for him, as he's progressed to rest pain, I do think it warrants an intervention. So the other two options are, as you said, endovascular and open surgery. For him, I think endovascular first is a good option because he's having rest pain and he has multi-level disease. So if you're able to even fix one level, that may get him out of the rest pain and significantly help him.
That's a great point. I love that point because I think a couple of things I want to ask you because, as you know, our audience is varied, but we still have a lot of interventional cardiologists who watch. So, rest pain is such a subjective thing, right?
Sure.
I may, as a doctor, say it's rest pain. The patient may not understand what rest pain is and says, yeah, my legs hurt, and then it may be interpreted. What are the objective findings in rest pain? Like, how can I tell you, Ajit, it's rest pain because of this? Beyond what the patient says, because as you know, our patients sometimes are not very clear on how to express themselves. So I'm curious on what can we learn as to what is rest pain?
Sure. So I think there's a couple things that I totally agree with you. It can be sometimes hard to differentiate, neuropathic pain from their diabetes from rest pain, and I think there's a couple things that can help. So one's the story that they give you. If they tell you they have pain in their foot and their toes at night, and that gets better when they dangle their foot off the bed, that to me sounds more like rest pain than anything else. Clinically, if they have on a physical exam, if they have dependent rubor, I think that's another sign. In terms of the angiogram, though, I think that's an important component. So someone that just has a focal stenosis in their femoral artery, probably doesn't have rest pain. Usually it's multi-level disease. So like this, this patient has multi-level disease and his angiogram's clearly consistent with someone that could have rest pain. Additionally, in terms of, I think non-invasives are important to kind of quantify it a little bit more. So, getting ABIs and PVRs and just seeing, what they are, which can, differentiate mild, moderate, and severe disease. So I think.
So that's a great point. So so you said ABI PVRs, right? And I think that's another thing. You have so here you have one criteria, multivessel disease. When you do the ABI, are you looking at ankle pressures? Because I know that SVS has different definitions in terms, because it's so confusing. You got all these societies. I follow a society, you follow a society, and we know everybody has their definitions. But my argument has always been to my fellows that we work as a team, right? Vascular surgery, cardiology, so on and so forth. So we need to be on the same page, at least on an institutional level. So my question is, what's the situation in terms of where we are with the definition of rest pain, in terms of ABI, ankle pressures, et cetera, et cetera.
Right. So again, I think it's like looking at the whole picture, but in terms of ABIs, generally, above 0.9 is what I consider normal. 0.9 to 0.7 would be mild disease. And really when I'm thinking about rest pain, I'm thinking about, moderate to severe. So under 0.7 for sure, and, under 0.4, I would expect rest pain or tissue loss. So I kind of quantify it that way. And then I also look at the PVR, the waveforms, because you can have patients that have bad diabetes and very calcified vessels, and the ABIs may be falsely elevated. So I look at the waveforms as well to kind of confirm my suspicion.
All right, and is there a definition with ankle pressure itself? Is it below 30? Is it DSA? Let's do a DSA. Is it below 30? Is it, what is the ankle pressure that we're looking for? Or below 70, 80, whatever it may be. Again, I just want to get our colleagues in the same page as you and me.
Yeah, I don't have a strict number that I use to, cut off rest pain. Like an ABI, I would say if it's around 0.6, 0.7 or under that, I would, I'd be worried more about CLI.
Got it.
Then,
Got it. So I think here we are. So our strategy, and I think that's a great discussion. Our strategy really has been exactly what you said. So I think for me, and which is great to have you here because we can talk together. So for me, when I look at this angiogram, and I always tell our colleagues, is that you need to understand like what are the things that can not only go right, but what can possibly go wrong, right? So the way I look at it is, well, here's a guy who's claudicating, he's at rest pain, but really has no tissue loss, right? So whatever said and done, he's not gonna lose his limb from this if we take care of his foot. We might be able to, improve him with exercise. We might be able to give him other things that may make him better. But if I make him worse, then I take a situation that's relatively stable without tissue loss and make him worse. So how can I make this guy worse? So again, when I look at it angiographically, those collaterals distally, especially that genicular collateral off the pop, which goes ahead and gives rise to both my posterior tibial and my peroneal, comes off that large geniculate right there to the left of your screen when you're looking at it, and or to the right of your screen, and you can see it fills both the anterior tibial, the peroneal and the posterior tibial. So my goal is I don't want to knock off that while I'm trying to attempt to do this. So the second thing is, if I don't want to do that and say, hey, listen, let's try to improve this guy, I may just want to improve the SFA, take him off the table, give him a trial of medical therapy, tell him to walk, and then come back. So, but what I decided to do was just say, let's see how this wire goes. If we're able to get in without doing too much crazy things, then that's fine. So what I did was I chose a field of wire, and we'll go over some of the equipment because I know we're all different in what we do. So actually, I'm sorry, I chose a command wire to take me down to the pop. At the level of the pop, I went ahead and put in one of our CTO wires here, the wind wire, and what I decided to do was to see where this wire is going. So at this stage, I'm taking the wind wire, and my goal actually was to get into the posterior tibial. So I seem to be heading in the right direction, but I really don't know, and so I decided to take some pictures. So it's important in terms of what support catheters we all use. We use a teleport catheter, which is a catheter from CSI. That's a very, very slick catheter that helps us in able to being tracking these. And it looks like we're kind of heading in the anatomical direction of the posterior tibial. But I went ahead and did some pictures, which didn't help us a lot. Because here's a picture looking for the distal posterior tibial. I think that's delayed filling of that vessel right there at the end is the posterior tibial, and I seem to be heading in the right direction. So I'm going to try to see how this works. I'm curious, what are the wires you guys use surgically? Is it similar to what we use? Is it different than what we use? When do you use an 014 or 018 or 035 wires? I think would help our audience a lot to understand how you guys approach this.
Yeah, definitely. I'll start with a caveat that I think a lot of it is preference, but for me personally, for femoral arteries, popliteal artery occlusions, kind of my go-to is to start with an 035 system. I prefer a glide wire. Depending on how soft or calcified I think the plaque is, I'll choose a floppy glide or a stiff glide wire, and then a quick cross catheter, Trailblazer, something like that. And I try to navigate through that. That's my initial approach. For something like this lesion, I kind of agree with going with a smaller system since we're working into tibials. So I like to start off with a whisper wire and a quick cross catheter, and then go from there. You know, if that's not working, then I'll try a V18 and a slightly larger system, an 018. But kind of my philosophy is to start with something that I think is going to be less traumatic and work my way up, because the last thing I want to do is end up in a bad dissection plane or, you know, perforate and then can't get back in. So I'm pretty conservative with how I start.
Right. I mean, I agree with you. And, you know, here it looks like you can see the calcium and we're sort of in the right spot, but you don't know. And, you know, notice I'm not really advancing my catheter. And I always tell our audience, you know, the beauty is you have to really figure out, and you as surgeons 100% know the anatomy of where this catheter, where this artery runs. As an interventional cardiologist, if it's a coronary or whatever, these guys are very good at figuring out sort of the pathway of the artery. But I think it's important to, by knowing your wire, moving your camera, really figuring out, well, am I in the right area for where the posterior tibial should be? So what I want to do just for teaching purposes is to take a picture here, see whether this wire is heading in the right direction before we advance our catheter and before we balloon. So, you know, I think most interventional cardiologists are using more the 014 wires and not so much the 018 wires. And I think you're right. I think that's very important for us to really have an understanding of what are the options. So we generally do exactly what you do. We start with an 014 wire like this, and then we're going to do a wire escalation technique. So, Ajit, one question for you. I know that obviously you can cut down, you can do whatever you need to do. A lot of the cardiologists are using pedal access very liberally. We've been advocates of not doing pedal first, and like for instance in this case we didn't go do pedal where I think a lot of people would have stuck to pedal. So my question is, what is your algorithm to do pedal, and when do you do pedal, when don't you do pedal?
Sure. So you know, it's a great point. There's a couple things I consider when deciding about pedal access. So the first is, you know, what am I treating? If I'm treating a patient that has claudication and maybe one tibial vessel, then I'm going to be very reluctant to mess around with that tibial vessel and stick it, because the last thing I want to do is you know, occluded or cause a stenosis and make them worse. So I think you know, what the symptoms are kind of guides me, and I'm more aggressive for patients with critical limb ischemia and with, you know, tissue loss. The second thing I think about is, you know, the number of tibial vessels they have. If they only have one tibial vessel, and I haven't tried an antegrade approach, then, you know, I would definitely be way more hesitant to try pedal access. But if they have,
I think that's very important point what you're saying, because, you know, clearly the antegrade access, you know, is more difficult, because as you can see we're pushing from up and over, or you could get antegrade, I guess, access, but you can see here I think we've crossed very nicely into the distal vessel here with just an up and over technique. All right, good. So we're definitely in the foot.
And then just some other things I think about is so also if they have an open option, so, you know, if they have one tibial vessel and, you know, I can talk about it more, but they have you know, a bypass option, they have a good vein, then I'm going to be much more reluctant to try Safari. If, you know, if I can't cross it, then I always have that option of doing the bypass. So that's another consideration. And then the last is which tibial vessel it is. You know, I personally, I really, the PT and the AT and DP are really the ones I go for. So depending on how easy it is to access is another consideration.
So out of the two, which is more easy to access, which is the area you access, and then go with that? Tell me, like, if you had say the choice of a PT or an AT, and say they were both robust, reasonably robust vessels you could get with ultrasound. Is your logic of getting the PT because it's better in terms of it's more superficial? Is it better to go with an AT? That's my question, because I think a lot, and also the location where you get pedal access is also very, very important. One second, Ray.
Sure.
So tell me, go ahead.
Yeah. So
speed.
Personally, and I don't know if this is the right answer or not, but if I have a choice in terms of proximal versus distal, I'll try to aim as proximal as possible, because I think you know, if I end up with some complication from the access site, I can always balloon or stent, and I'd rather do that in the proximal PT than around the ankle or whatnot. But I don't know if that's, I'm sure there's different preferences on that. In terms of AT versus PT, I don't have a strong preference. I personally think in a patient that is, has a high BMI and a large leg, the PT can be a little bit harder to access proximally, but I think both are reasonable and accessible.
So the other phase, the other thing also I think is relevant in this conversation. I think in CLI, you and I both agreed that it's a reasonable point as long as you're doing the right indication to go after these pedal vessels as access. A lot of cardiologists and probably surgeons, I don't want to say one field or the other, a lot of people out there, let's put it that way, are getting pedal first for treating the SFA. And especially in the OBL setting where they're saying that, hey, you know what, I can get pedal first, it's similar to a radial, let me go through the leg, do what I have to do, put a Band-Aid or a little pressure on the patient and send the patient home. So, this has become a trend, and you and I both know there are lots of our colleagues who we respect for a lot of reasons have been kind of advocating this as well. And I know I've found it. I'm sure you've gotten transfers. Actually, you've dealt with some of them that we both have dealt with, who have had these kind of bad disasters in OBLs because of poor visualization on pedal first. So, what's your thought on pedal for claudication? I think that's an important topic for what we do.
Yeah, so personally, I don't advocate for doing pedal access in claudicants because like we kind of mentioned before, I don't think it's worth the risk of making them worse.
Right.
And turning them into critical limb ischemia patient by if you have any access issues with the tibial vessel.
Or closure issues.
Yeah, exactly. So I just don't think it's worth it. Especially in someone that has one vessel runoff, and if they're claudicant for whatever reason, I would strongly consider not touching that tibial vessel. But maybe perhaps I'm just more conservative, but that's just.
No, I personally think you're very appropriate, like we are. I mean, don't get me wrong. I mean, we've done pedal to cross a lesion. We never treat through the pedal primarily. That's never been our goal. It's always been let's do access and then go up and over if we have to, and then go ahead and then treat from some other some other way. So, for instance, crossing a occluded SFA using an 018 wire from the foot without putting a sheath in. Go up here, guys. Without putting a sheath in. So, just for the audience here, what are we doing here? We're ballooning with a 2.0 balloon. We know we're in the posterior tibial by the way the wire moved. Go ahead, go to 10. With an severely undersized balloon.
10. Just
to get just a lumen down. And I don't think we're going to knock off any collaterals with a 2.0 balloon. I'm going to pull back here. And I'm just going to balloon the pathway. Go to 20, please, each time. And all I'm doing is just opening up 20. A channel, 20. So all I'm doing is opening a channel to get a support catheter down. And then what I want to do is confirm my position. And then we'll talk about what we're going to do here. Go up, please, to 20. And then we'll talk about what to do. So as far as anticoagulation, we've used bivalve down. I know that a lot of people use heparin, which I think is fine as well. We just use it because, we get it. We go ahead. We use it for the coronaries, and as you know, there's safety data with bivalve in the peripherals down. And so for us, it's sort of like a lab preference, nothing other than that. And so, as you know, also with perforations, people are concerned with perforation with bivalve down. But from the coronary literature, if you have a wire perf with bivalve go up, especially in the heart, the chances of having tamponade are very, very low. We just turn it off and watch the patient, and it generally it does not produce tamponade. So, it's in our experience, we're actually going to publish that. Go up, please. That bivalve is extremely safe in the peripherals, even in the perforations, as long as you don't have a balloon perforation, wire perforation down, are not an issue. So we're now ballooning. I'm still going to take this balloon further down to really try to get into my distal posterior tibial. Hopefully it'll go. Let's see how far I'm able to get it. Yep, it's going much further now. So let's go up here again, please.
Okay, going up. Same 20?
Yep, go to 20 here. It's only a 2.0. It's a big vessel.
Okay.
Down.
20.
You had mentioned that this patient doesn't have a good vein, correct?
Yeah, oh yeah, yes. So we did do vein mapping, which is interesting because of rest pain. He does not have good vein.
20.
And it's very difficult to get vein mapping in-house. We had to bring him back twice.
Down.
I'm on a high flora here, guys. And I don't want to be on high flora. See? So that's another question. Can you talk about PTFE versus vein for a bypass? Go up here.
Yeah, definitely.
Okay.
So first, I think that brings up an important point is, I think it's very
20.
important to potentially have the vein mapping before you, proceed with an angiogram if you know what you're treating in this case,
Go up here.
because it gives you a really good idea of how aggressive, potentially you can be with the endovascular.
Put me down.
If someone has great vein and is a great bypass target, then bypass candidate, then you might be more conservative with the endovascular.
Go up.
So in this case, I think it's great that we have vein mapping because we know this patient doesn't have good vein and
20.
Down.
can potentially be more aggressive.
And also, just I think it's also important just to comment on one thing that I know we've done together is not to angioplasty too below. You know what I mean? Go up. Where I know that he has a distal reconstitution of this vessel
20.
where technically you could do a below knee bypass if you needed to, and so we try not to go too low. We're just going to go ahead and balloon up to that reconstitution zone. And then I'm going to go ahead and now put a support catheter and change this out. Because a lot of time I think cardiologists just go ahead and balloon all the way down. And there's no reason to because, why do you need to balloon past and create barotrauma, which may do this? Now, it brings me to one point before you talk about PTFE versus vein, which I think is an important thing to talk about. In basal, it showed that the patients who had endovascular first ended up with more amputations and worse outcomes after they had bypass. So first of all, do you think that's true? Do you think that we need to not do endovascular if he's a bypass candidate, let him go directly to bypass regardless? Or do you think that's I don't know, what's your opinion on that is more my question.
Yeah, no, that's a great point. I think I think you alluded to it. I think you can make a patient have worse outcomes or make them a worse bypass candidate with the endovascular intervention if you're overly aggressive with the target vessel. So like you said, how you don't balloon distally so that way the patient still has a good bypass option. I think those are all like important points, or not stenting the the target location in the tibial. I think those probably in part contributed to why endovascular first wasn't kind of like a free gimme without any consequences. So I think it's just how you manage the target, and if you still preserve it and there's no change, then I think it's still safe to do. So I think that probably in part explains why they saw that.
Yeah, I agree, because I think what happened was they probably angioplastied the areas where you could have bypassed to in the future, like where I am right now. I think this is an area where we know the artery is, there's no healthy artery in a diseased artery, but a relatively healthy artery compared to an occluded artery, where you would bypass. So unless I embolize or dissect, and people talk about this all the time, I think unless I embolize or dissect, it's, I'm not going to make this person worse. How can I make them worse? Well, I can knock off the genicular collateral and not succeed in my intervention. Well, that's going to make them worse. Number two, I can embolize something, shut down my distal vasculature. That's going to make them worse. Three, I can dissect the vessel shut distally. That's going to make them worse. And four, I can angioplasty the crap out of the entire foot. And then all of a sudden now, a year and a half, 2 years later, when he progresses, you go to bypass, we do an angio, and nothing is open. So I can't imagine if I don't traumatize the distal vessel where you can target that it's going to get any worse. I'm not sure. I think we need to have, I don't know how you evaluate that, but I think that's a discussion that needs to be had with the vascular surgeon, the patient, kind of illustrating our multi-vessel approach, our multidisciplinary approach on this.
Yeah,
so I think that's very helpful for our audience, that little discussion. Let's talk a little bit about vein versus PTFE.
Yeah, sure. So in terms of, when I'm assessing someone for a bypass surgery, there's always three things I think about. One is inflow, making sure there's no proximal lesion that generally you can treat with an endo approach. Conduit, which we'll talk about in just a second, and then outflow. Outflow meaning what what blood vessel I'm sewing to, whether it's a healthy tibial vessel or a popliteal artery with one tibial down to the foot, or 3 vessels coming down. So I think those are 3 things I think about. And so in terms of conduit, the preferred conduit is saphenous vein, and I think that becomes more important as you cross the knee joint. Because it's been shown, that the patency of a graft does far worse when you cross the knee. So definitely doing vein mapping and seeing if you have good vein. Good vein meaning that it's size-wise, it's 3 millimeters. 3 millimeters or more, and it's not thick-walled, nothing like that, no clot in there. So those are all important things to consider.
I think that's a great point. You said so good vein. So good vein. What are the criteria? Because I don't think cardiologists understand that. And I think, or even radiologists may not understand. Like, what is a good vein for bypass?
Yeah. So it's a good point.
I know
so
you said that, but I kind of want to break it down into like criteria,
Sure.
like A, B, C, and D.
Sure. So I think number 1 is size. There's been data that shows if it's above 3 millimeters or above, it will do much better than if it's under that.
EXL2, right?
So I think that's number 1 that we all look at. And then, 2, less important, if it's thick-walled or it looks diseased or,
3035.
There's some clot in there. I think that's number 2. Number 3 is size mismatch. So as the vein goes more distal to the foot, it can taper down a little bit. So that's just another thing to consider, whether you want to, that comes into play, whether you want to reverse your vein. So that way it's more size matched to the arteries that you're sewing to, or if you don't want to reverse it and then lice the valves. But I think the most important thing is honestly the size. And again, it's like 3 millimeters and above is ideal.
Can you talk about these anastomosis, well, enticide, whatever, I read this in some of your op reports, vein patch, all these kind of things, like when you use PTFE, because again, I think these are languages that if you're going to do the endovascular field, you need to understand, because you got to speak the same lingo. Like cardiologists need to understand about task, and cardiologists needs to understand about the Wi-Fi classification, so on and so forth. So I think these are things that I think we need to talk about. So tell me about those patches and those enticide and all that stuff that you guys use.
Yeah, so because like we mentioned, the graft patency is much lower than the vein. We try to do things to kind of boost up the patency for the graft. So if we're doing a fem tibial bypass with graft with PTFE, there are 2 things that kind of people consider. I would say the most common by far is what we call a vein patch. So that's where on the tibial vessel, where we're sewing onto it, we actually, there's different ways of doing it, but you harvest a little piece of vein, and it just has to be, a couple centimeters, something small, you can get anywhere really, and you can make like a cuff around the tibial vessel, and using the vein, and then sew your graft onto the vein. So that way, basically, you're putting a piece of vein in between your graft and your tibial artery. And the idea is, whether that helps with intimal hyperplasia or whatnot, that your patency can be a little bit better. So that's actually, at least at this institution, quite commonly done, where we do a vein patch to try to improve the patency. So that's number 1. Then the second thing that I don't personally do, but that's described as creating a Av Fistula. There's some surgeons that advocate for that. So where you actually do your bypass and then you create an iatrogenic fistula between a tibial vessel or whatnot. So that way your outflow is theoretically improved. I personally don't have experience with that, and I don't think many people do it, but it's a second option.
Got it, an AV fistula. Okay, that's good. So you can see here, we went with a 3035210. I believe here that the lumen gained is going to be huge in terms of his patency. So we try to use as big a balloon as he can tolerate. So he did have some discomfort, as you can imagine, because I was probably subintimal as I came in. So we went distal to where we think the reconstitution zone and proximal to just below where it occludes. So now what we're going to do is we're just going to leave this balloon up. Let's talk about the technique of balloon angioplasty. Obviously, sizing we just mentioned is very important. You need to be at least at least 1-to-1 size, if not a little bigger, if you can get away with it. Second is, what is your duration of balloon angioplasty?
Sure. So in general, I think it depends if you're using plain balloon versus drug-coated, but in general, I do 2 minutes. That's just kind of how I was trained. For some of the drug-coated technology, which I guess is a whole other story now, but we do 3 minutes. But for plain balloons in general, I do 2 minutes.
So that's great. I mean, we do about 2 to 4 minutes, depending on whether it's a CTO or not. Obviously, it's not a heart, so the leg can tolerate ischemia very well, and he is an ischemic leg. So at this stage, what we're doing is we're just going to leave it up for like 3 to 4 minutes. And also, it depends on what our goal is. Like, ideally speaking, I've consented this gentleman for drug-coated balloon technology. He's at a very high risk for restenosis. The FDA obviously says in high-risk patients it may be a viable alternate to using, to normal therapies. And I've explained to him, and he's one who kind of told me, Doc, you do what you think is right for me, and I've said fine, and this is what I think is right. So my goal is not to stent this pop, because I believe that stenting the pop, although it's an occluded vessel, you would have never bypassed to it. I just think it creates a conundrum of problems later on that we have to deal with. So it would be nice if I could just balloon the tibial, have no dissections, maybe plus minus atherectomy. We'll talk a little bit about that. And then maybe drug-coated balloon the pop with a 4 or 5-0 after IVUSing it. So I kind of look at my goals of what my end game is after I've crossed, and then kind of tailor my therapy to that. Because as you and I know, algorithms are as different as us. I mean, you take some interventional cardiologists or surgeons, and they believe in stenting everything. You take some, and they say, oh no, just balloon it and leave it. Let's see how it does. And others will be like DCB or drug-coated therapy is the way to go. So unfortunately, there's no consensus. But what I try to do is use logic and say, okay, well, listen, I don't think I have the holy grail here. Nothing is going to make this stay open for the next 10 years. And so my idea is, well, what's my next therapy? And that's kind of what I look at. So I think it's important for the audience to hear your perspective as a surgeon, because obviously you can do things I can't do. You can do a bypass. You can do other things, endarterectomy, and all these other things that I'm not able to do. So that's kind of the question on to you, and what's your algorithm for decision making in a difficult patient like this?
Sure. So yeah, I think that's a good point. So first thing is like what I'm treating, and where I'm treating. So in this case, we're treating popliteal artery into the tibials. So the one thing that I think comes to mind for me is it's not really an area I want to stent. With the the fluxation at the knee joint, I just don't think stents do well there. So that kind of impacts my decision. So for me personally, I think about trying to debulk the lesion with a atherectomy device, and then ballooning it and see how he does. Because atherectomy, I think lowers your chances of needing a stent. So I think that's one important point is where am I, and is stenting a good option here? So for this lesion, I don't think it's a great option. If I was in the middle of the SFA, then sure, I'll put in, I'm more likely to stent, because I don't think that's going to mess up my bypass if, that patient needs a bypass down the road. So in that case, I'm more aggressive with stenting. So I think it just depends where you are. And then, yeah, that's probably the main thing. And then the second thing is also, along with the stenting, is I don't want to stent anywhere where I could potentially sew to or sew a bypass onto. So if I'm getting to, above knee pop that comes back for an SFA occlusion, I'm going to try to minimize my stenting near that point where the artery comes back, because I don't want to ruin that target down the road.
That's a fantastic point. I think as cardiologists and probably radiologists as well, we forget that other option since we don't do it, and we're like, oh yeah, let's stent it. Oh, the water looks great, it's open. But the point is, yeah, it looks open at that moment, but these things aren't going to stay open. I think that's a great point. So Ajit, Haroon has been kind enough to prepare some presentation for us. I just want to go to that, and then we'll come back to our discussion. So to the audience, while Haroon is presenting, we're going to put whatever I'm doing on the side next to Haroon's presentation. Please make Haroon's presentation large so he can see it, and what we'll do is we'll go ahead and continue to work. I just want to give an idea to the audience of what we're doing. We're balloon angioplasting right now. We're gonna do an intravascular ultrasound, and then do an atherectomy like Dr. Rao and I both suggested, and then we'll come back for our final therapy by the time Haroon is done. So go ahead, Haroon.
Okay, can you put up the slides, please?
Down, right in the center.
Okay.
Okay.
So let me just go through the incidence of FEMPOP CTOs. This FEMPOP CTOs are encountered frequently in 40 to 50% of cases. Patients presented with claudication and CLI.
You got to make his slides
FEMPOP
bigger, guys. Forget about me. Forget about looking at me. Just put the angiogram and the slides. Great. Thank
Okay,
you.
thank you so much. The FEMPOP CTO revascularization is both indicated and feasible in patients who are refractory to medical therapy and who have failed exercise therapy and classified as type D lesions. So I would like to touch upon an interesting article by Dr. Banerjee and group that goes through a step-by-step approach for dealing with these CTOs. The morphology of the cap dictates the type of lesion. For example, there are 4 types from 1 to 4, and it is important to take that into consideration because we can use this for choosing the optimal strategy for treating these lesions. In terms of initial crossing the lesion, there is a multiple factors that are useful in choosing an antegrade or a retrograde approach. For example, the ambiguity of the proximal cap versus the tapered or suboptimal target vessels. In this case, the patient that we have, he qualifies for a possible type 2B because of the tapered proximal cap and suboptimal target vessel and a long length lesion between 50 to 150 millimeters.
Go down further. Go down
for crossing the lesion, there's multiple options available to us. For example, we can use a wire catheter technique versus a dedicated catheter crossing device versus a dissection and re-entry into the lumen. This is dictated by a number of factors. For example, as you can see on a slide, the figure on your right, the proximal cap, the number of side branches, the CTO body, and a total CTO length. In terms of the equipment selection, we have a number of choices available. For example, for guide wires, we have polymer jacketed wires, which are hydrophilic wires and are useful for crossing subtotal or a severe tight stenosis. In our lab, we use a command wire.
2530.
And for non-polymer jacketed wires, we have multiple options. For example, a starter 20
and 25 long.
and a confianza wire. The other options available to us in terms of equipment are crossing devices, ADRs, and retrograde specialty wires. We'll go through them in the subsequent slides. In terms of the platform, we have multiple options from 035 to 014. Each one has its own benefits. For example, 035 is good for better support and stability, 018 for steerability and flexibility, and 014 for re-entry and least trauma to the vessel. In terms of the crossing devices, as you can see on your right, there's multiple options available in the market. For example, TruePath, FrontRunner, Crosser, Wildcat. All of them work by exploiting the microchannels and considered a secondary technical success device. In terms of the subintimal dissection reentry, we have a number of options available. As you can see on your right, there's the Interior, Pioneer, Outback, and Off-Road. Pioneer is unique that it utilizes IVUS as part of its structure and is useful to re-enter using an IVUS guided re-entry into the lumen. At this point, I would like to bring upon the third and most recent update from FDA that talks about the higher mortality signal in patients receiving paclitaxel and drug-coated balloons and drug-loading stents. The most recent update recommends that when making treatment recommendations, the physicians should have an informed consent as part of letting the patient know that there's an increased rate of long-term mortality associated with these devices. Additionally, an alternate treatment option should be provided to the patients, and they leave it to the physician to choose which patients will benefit based on the risk and benefit ratio, such as patients who are at high risk of restenosis and subsequent reinterventions such as ISRs. So in our lab, we've been using bare metal stents. These are devices that we use in case there's a dissection after the intervention. For example, there's a superior interwoven nitinol stent which has excellent patency rates, as you can see, from 68% up to 88%. And traditional nitinol stents such as Everflex and Life Stent, they have excellent patency rates as well.
Laura, save that.
Now, in this slide, I would like to mention 2 important points about the superior stent. Number 1, we need an excellent vessel prep and a good compression to elongation ratio. This is important for achieving excellent patency rates. And lastly, the other 2 stents available in the market that utilize the traditional nitinol stents are the Everflex and the Life stent. Both of them have comparable and excellent patency rates up out to 3 years. Okay, thank you so much. I would like to thank Dr. Krishnan, Ray Rascano, and Raza.
Don't forget Dr. Rao.
And Dr. Ajit Rao, of course, for his presence. Thank you so much, Dr. Rao.
Okay, so Ajit, I think, that presentation is great because it goes over kind of everything we talked about. What is this? IVUS. So in the meantime, let me show you what we've done. Go ahead with scene minus times 2, please. So we did our balloon angioplasty like you and I spoke for 4 minutes. And then minus, go to the picture. So you can see here, and it's a good picture, minus. You can see here, minus, yeah, right here, this is good. So you can see here that this just with a 3530, the pop is opened up nicely
nice.
into the posterior tibial, and then plus. But I want you to notice, and I know you do this, and we talked about it. See how we ended the balloon angioplasty, and you can see there's a disease segment that we didn't touch because that collateral, that competitive collateral, is kind of where it reconstituted. So I was very conservative taking my balloon all the way down because I didn't want to go into the healthy vessel. Now I identified that spot, and then now go plus, and I balloon with a appropriate size balloon of 2.5 at that level, left it up for another 2 minutes, and we didn't take a picture yet. So we're going to do an IVUS now, and I want to figure out whether we should DCB it or not, and then talk about it because we have a pretty good result here. Maybe not DCB, just atherectomize it and leave it alone. This way. I mean, the one thing that we don't know is DCB in I guess these kind of rest pain type of patients. There was some controversy, as you know, back in the day with the below knee trial and DCB with the Covant balloon, but we know that balloon's no longer even on the market. But with everything that's going on, maybe at this stage we leave it alone. Okay, IVUS, please go on IVUS for Dr. Rao so he can see it too. Let's go live. You're live? Okay, I'm going to pull back here, Ajit. So there's an IVUS from below. And Ajit, you can see the severe calcium, huh?
Okay, yeah, I see it now.
How is it to sew to these vessels? Is it very difficult?
Yeah, and a diseased tibial, it can be very, very difficult. Because one, you could have clamp injury if it's not a healthy vessel. So that's a potential. And then even sewing to it's very friable. It can break off. So yeah, it can be very, very challenging. And they're obviously
interesting. We're very intraluminal all the way down, right? The plaque is very minimal at this level, or we pushed it aside nicely. And now we're getting into the pop. I'm fluoroing here, not yet quite in the pop, still the posterior tibial.
Question for you: do you routinely use IVUS in this for these procedures?
We do. If you look at at least some of the, I know data is not the best in everything. With DCB, it seems to be like sizing is a big issue. One-to-one sizing of the DCB. See here is a lot of diffuse plaque, but we're still intraluminal all the way, which I'm very happy with. But yeah, we use it mostly for sizing. And then if there's any eccentric plaque like it is right here, we know that atherectomy may benefit this patient, and right here, look at that. So we have a little dissection flap there that we know we have to deal with, possibly stent. Angiographically, we didn't see that. And then now we're coming all the way up. So yeah, so now I'm going to ask Damien to measure the last part of this, Damien, the end of the IVUS, just so to get an idea of what I want a DCB. And I think I'm just going to run an atherectomy device through. Give me an EXL, guys. I'm going to undersize my atherectomy device just to open it up a little bit, probably not take it into the posterior tibial, just do my popliteal, and then go ahead and possibly DCB balloon it. Let's see, let him get a vessel size. Right there is pretty good, Damien. That's, no, is that the SFA? No, I don't want the SFA, I want the popliteal. Yeah, no, actually, that's good, measure right there. That's definitely the pop, yep. So he's going to give me a vessel size for me to see whether it's a 4. As you know, as far as supera stenting, I know that Haroon didn't quite hit on this, but you know the size of the supera matters. If you do a 6.5 or a 6.0, at least in our experience, see the diameter is around 4.4, so we can use a 4.0 or a 5.0 DCB without a problem. I'd probably use a 4.0 just to not dissect this and have to stent it. So as you know, with the supera, back to our point, you know, fracture is not as much an issue with supera as it is with other stents, the older generation nitinol stents. However, vessel prep is incredibly important, and I believe the supera size is very important. We do not use the 4.0 superas or 4.5 superas because I think that the 4.5 superas are really, our restenosis rates are very, very high with those. So we tend to use 5.5s and up, some 5.0s here and there. So I'm going to try not to stent this on, please. So I'm just going to go ahead and do a little atherectomy. Off, please. And not yet. And I'm just going to go a little bit further down, and then try to use a 4.0 DCB to try to give some medication to this. On. I undersized my atherectomy on purpose. Off. Because I am going to go into that trifurcation area. On, please. And get this spot right here. Always got to watch out for atherectomy bias. Off, please, because that can end up with a perforation. So give me a 4.0 100. Okay, let's talk a little bit now. So I've decided to use a DCB. Would you DCB this if you have consent to the patient, or would you leave it with a balloon?
So yeah, I think that's a pretty uncertain. There's no consensus.
Right.
Personally, I still have been very conservative with using drug-coated technology, but some of my colleagues use it with the consent, like you mentioned.
Right.
So I think it's honestly just preference and kind of waiting it out until the FDA or whatnot, some governing body gives us a little more clear recommendations.
Yeah, it seems to be. I don't know. I know we all read different journals, and that's another issue too, Ajit. We all read so many different journals. I know you guys read JVS. I do as well. But a lot of some of the major trials are coming out in cardiology journals, like JACC and other things. And you know, there was a recent editorial by our very own Dr. Olin about DCB, and it was interesting, you know, because it's completely against sort of the consensus of wait and see what the FDA says, which I think you and I at least are on the same page on that. But you know, his argument was that, you know, the data is flawed. You know, there is no safety signal, so on and so forth. For those of you who haven't read it, it's really a fantastic editorial by Dr. Olin and Dr. Gray. But I agree with the JIT. But let me give you my logic on why I'm doing this. I'm doing this because I really believe that this patient is at a high risk of restenosis. So I'm just going to take it a little over that bend. This is where there's going to be a little dangerous, but let me see. Show me above. And I balloon with the 3.5. So let's go with the 4 very slowly. So so this is the reason I'm doing it. I think the restenosis risk is very, very high on this patient. And I think that I'm not burning a bridge if I do a DCB, because a couple of reasons. I don't think you would have bypassed this occluded vessel anyway. I've not gone too far down. I've not knocked off the collateral as of yet. I mean, things may change after this. And I think that overall, you know, his patency may be improved. At least with impact, we know that, you know, the patencies do improve in complex lesions. So we're going very slowly with a 4.0 DCB. And what you said 4 atmospheres. What's nominal? 8. Go slowly to 8, please.
You know, I definitely agree with you. I think in a high risk for restenosis or occlusion intervention in a patient with like CLI, it's perfectly acceptable to use, because
3 minutes.
Like you said, I think this will definitely improve his patency. So I agree with you.
All right, so here we're going to 8 atmospheres. Obviously, it's discomfort. We know he's going to have it. So we're going to watch paint dry for a little bit, and we'll discuss a little bit more. Follow up on these patients, Ajit. So now you've done an intervention. I know there's no consensus. Everybody's different.
Right.
And I think, you know, part of this conference that we do on the internet, I think provides a lot of perspective to people on what other people are doing. And I mean, the fact of the matter is, all of us together at Sinai, probably the biggest vascular surgery, vascular interventional group in the country, from what I hear from the companies, one of. So I think that, you know, what we do here is very important. So how do you guys in your department follow these patients post-intervention?
Yeah, no, I think you kind of hit on it. Some of it's preference. For me personally, so I'll see the patient 2 to 4 weeks post-op, and generally get a repeat ABI or arterial duplex then. depending on what I find will kind of determine whether, you know, where the next study is, but generally it'll be 3 to 6 months if everything looks okay. And then kind of keep it in that range again, and depending what the symptoms were and, you know, what the risk for restenosis. Like in this patient who has a very complex multi-level, you know, disease, I would follow him closely for sure. But yeah, my first imaging would be within the first 2 to 4 weeks.
Got it. And then what is your criteria to re-intervene?
Yeah, so great question. So I think one is, you know, what the lesion was, and so in this patient, you know, symptoms would probably dictate a lot of my decision. If
Yep.
if his rest pain's getting, or if he's having recurrent rest pain or whatnot, and it's getting worse, then I would definitely be way more aggressive with him.
Right.
If he has a borderline lesion, but he's asymptomatic, I may just monitor it and see how that progresses. If he was like a bypass patient, though, for example, and he had a really high-grade stenosis, even if he's asymptomatic, I would still treat him, because if that thing brings down the whole bypass, then he's going to be, you know, where he started off with, if not worse.
Well, you know, it's hilarious that you say that, because, you know, I'm the big advocate on that, because I agree with you. Like, you know, this our surveillance, quote unquote, is really derived from the bypass literature. But the natural history of a down bypass is completely different than the natural history of an endovascular SFA, for instance, you know? So I think that, you know, as cardiologists and probably even vascular surgeons are guilty of this, we intervene based on PSVR ratios. And you know, while in a bypass, absolutely you should to save the graft, I don't necessarily think that's true in an endovascular case. So, you know, but the problem is we don't have any objective evidence of saying, oh, okay, yes, okay, this PSVR, the patient is symptomatic and we should do it. We don't think like that. We have a knee jerk. Oh my God, you know, it's a doubling of the PSVR. The guy's getting a restenosis. I have to do it. Well, it's a totally different natural history of our intervention versus a bypass. And I think that's a great point that you make. I do also believe in objective exercise testing. And I think if we can get them on a treadmill, you know, especially if our PSVRs have done, and see, well, what's the walking distance of this gentleman? You know, what happens to his symptoms when we put him under a stress picture, and then we'll do it. So we did our DCB. We're going to take a quick picture here, because I promised you an hour. We're at an hour almost here, and I just want to make sure that we can close this up for you. I know you have a big day today at work, so you can see there's our nice popliteal. I'm not going to do anything further to that. Go a little lower, please. And I think this is a little very, very important. Open up your shutters here, guys. Okay, a little lower. Okay, now I want to make sure my collaterals are still good to the perineal. Inject. I think this is an important picture for all of us, because you don't want to create any damage. There's your collateral to the posterior tibial, and let's see if the perineal comes back. There it is. And there's your anterior tibial coming in. Nope, it's a collateral again. So we haven't messed up our collaterals. Show us a foot shot, please. Now I'm just going to pull my wire back a little bit so I don't confound anything. Now wide, open it up nicely, please. Show me the whole foot. Okay. Inject. So there's our foot. Beautiful. So I think we're going to stop here, man. I mean, I'm not going to chase this. I don't want to put a stent in if I don't have to. And you know what? I'm not even going to touch that proximal stent, because I told you the PSVR ratios weren't something that was significant. I think that if I do more, I may embolize from that at this stage. We'll check if he has a palpable pulse. We'll do ankle pressures, and then we'll see how he does. And like we did, as far as anticoagulant, we're going to use the same thing that's recommended, which is aspirin and Plavix, and we'll put him into a surveillance program. And like you said, we'll follow the way we do. So listen, it's about 1 hour. I think we made a nice demonstration of the thing. I want to thank you on behalf of our team for the very last minute adjustment you made to our schedule. You know, I really appreciate it, and I think that's incredibly important, your contribution, and I can't thank you enough. I also want to remind our audience that you know, Dr. Rao I'm going to give out your email if you don't mind for any questions. It's ajit.rao@mountsinai.org. If there's any questions, just like our emails are prakash.krishnan@mountsinai.org. Please don't hesitate to email and reference this live case if you have any questions directly to Dr. Rao or to myself. I also want to remind our audience that our next live case is Wednesday, October 23rd at 8 a.m. And that's the fourth Wednesday of the month, as is. So on behalf of our team, on behalf of Dr. Rao, I'd like to thank all of you for visiting with us for the last hour. And this will be archived in our website, ccclivecases.org, and I appreciate it. Thanks, Ajit. Really appreciate it.
Thanks for having me.
Thank you. Thank you.
Thanks.